breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Kolby Condos.
All right, everyone, welcome back to this week's episode of Brainstorming with the Docs. I'm Dr. Kolby Condos. My co-host, as always, Dr. Glenn Harrison. How's it going, buddy?
Doing great. I'm looking forward to this one. And
this is a good one. This is one that has walked into my office frequently the last couple of months. It's something that the guest host or the guest on this particular podcast is incredibly well versed in. And we are actually discussing what is called postural orthostatic tachycardic syndrome, or POTS. If this is your first time watching or listening and you know someone that may have POTS or you might suffer from it yourself, you definitely are not going to want to miss this because it is chock full of information about why this is happening and what you need to do and who you need to look for and to get better. So please enjoy this interview with my good friend, Dr. Mike Lovich. Dr. Lovich, how's it going, buddy?
Fantastic. I feel like I'm finally on here because otherwise we'd be cracking up too often. We had to mature to a certain age.
Yes,
I know. Sit on a podcast together.
So for those of you that don't know, some of you actually met Mike if you've been my patients for a long time. I've been friends with Mike for about 10 years now. Dr. Mike is originally from New Jersey. He then moved to, Portland to attend school. And that's where I met him, was actually when we were interning at a neurology clinic in Portland. So why don't you tell us a little bit more about yourself? And we're going to talk a little bit today about a condition that's called POTS. It's something that's popped up more and more commonly and is becoming increasingly prevalent amongst populations, especially after some of the infections that we have going on. But before we get too deep into that, why don't you just kind of tell us a little bit about yourself and how you kind of got involved in all this kind of stuff?
Oh, for sure. So this all started actually when I was interning in the dojo of Zelinsky with Dr. Condos here. So there was a patient that came in who couldn't stand. He was walking and being carried by his wife and his daughter, and he was helped along into the room, right onto a table that tilts up. And I was like, "What's going on with this guy?" It's nothing I'd ever seen before. And I'm volunteering in a clinic at that point where you see a lot of weird stuff. And one of the other doctors there, Dr. Reese, looks over and he goes, "Oh, that's POTS." And I'm like, "What's POTS?" And then I start learning about it. So this was approximately, about 10 years ago, 2012, 2013, when I started learning about this stuff. And since then, I graduated, moved out to the East Coast, started a business out there, and have slowly expanded it. So my business is called Delta S Performance. It's a functional neurology, sports medicine, chiropractic office. We've got 4 doctors now. We're bringing on a 5th doctor in spring of next year. And we have a specialist in functional neurology in each one of our offices. And one of the things that I think is so important about that is because when you've got these complex conditions, it's kind of hard to fly places. It's kind of hard to travel. Just the idea of changes in air pressure on a plane, or even sitting in a car where, there's motion on the road, could rock a person's world and ruin their whole day. So one of the things that I thought was super important was we shouldn't all have to have these giant clinics where people fly in from all over. It would be nice if we could have a clinic with a doctor that's well-trained and able to get patients better in most metro areas. So that's my goal. My goal is to have a clinic in almost every major metro area in the country. And right now I'm up to 1, 2, 3, 4, 5. So working on it.
Yeah, big goals. I mean, that's a good thing. I mean, people are dramatically underserved when it comes to this type of care. I think it's really unconventional. It can help things that people have thought unhelpable otherwise, I guess, for lack of a better word. I think that a lot of people have lost hope in a lot of cases where they haven't gotten help through pharmaceuticals or through physical therapy or something like that. And sometimes it just takes a new set of lenses and a different set of tools
for people to get better. So I do applaud you for that, because I think it's really cool. I think it's a big goal and a big dream and a big aspiration. And I really think that it's going to serve humanity quite well if you can get it to where you want to do it. Right.
I sure hope so. Like, the goal of this isn't to get rich. The goal of this is to provide services for people who need it. And so by following this mission, we're achieving success one step at a time.
Right. So, well, that's a little bit about yourself. So why don't we talk? I know that we've, when you and I talk pretty frequently, you were recently on a podcast that was called Potscast, and you'd sent me the link and I'd listened to it and I thought it was super interesting. And I know that not a lot of people have heard about POTS before. And what POTS stands for is positional orthostatic tachycardic syndrome, right? And when you look at that, can you explain a little bit more in depth what that means and what it might look like?
Yeah, I think the P is postural or
postural. Sorry, not positional.
No, I keep saying positional too, and then I looked it up once. I was like, oh no, I got to make sure I say that correctly. So let's think about how the brain works and how the brain is supposed to function appropriately. The brain is really just there to figure out where you are in space and when the world is around you. If your sensory systems that figure out the answers to those two questions aren't working well, so your eyes, your inner ear, and your muscles and joints aren't saying the right things and also aren't saying the same thing, then your brain is not going to necessarily be able to respond to things and keep itself standing up. And it's going to have a whole host of problems. And there are going to be a lot of like weird, vague neurological problems that are all dependent on your brain's ability to figure out where you are in space. So the hallmark of patients who have POTS typically is a pulse spike, which means that when they get into a certain posture or they change their position as well, go from lying to sitting or sitting to standing, their pulse will spike. But let's rewind that a little bit and figure out why that's happening. So when you go from lying to sitting or sitting to standing, what's happening is gravity is pulling on all the fluid in your body. And let's talk about blood. So it's going to pull the blood down. For that split second in which the blood is being pulled down, there's going to be a little bit of a low pressure system right over here where you have your baroreceptors.
Yep, in your carotids. Yeah,
in your carotid bifurcation inside the carotid body. And what ends up happening is patients who have this issue, their brain is not responding as appropriately, as quickly to, oh, blood pressure got low. Let me raise blood pressure an appropriate amount, which is like 5 to 10 points. They stand up, they get 5 to 10 points higher blood pressure, then they're standing there, blood volume gets back to normal, and then it comes to their normal resting blood pressure. What happens with patients with POTS, at least from what we've seen in our office, is the blood pressure will drop and it won't react. And what happens when blood pressure goes low? You'll have a reflex in your body, an automatic process that's supposed to be there that will spike your pulse. If blood pressure goes low, you spike a pulse in order to maintain blood circulation throughout your body.
Which kind of makes sense, right? If your blood pressure goes low and you don't have any blood in your head, what is your heart going to do? It's going to beat faster, right?
Yeah.
Like, oh crap, it's not going beat. You got to go quicker. Try to get it up there.
And the normal response to this is just to have a little bit higher blood pressure. We're talking 5 to 10 points. So what ends up happening with a lot of these patients is it's not so much about the name of the diagnosis. It's in our office and your office as well. It's more about what is the pathophysiology, what is happening with the patient individually, and what's going on with those brainstem systems that are supposed to regulate all those autonomic functions.
Yeah, it's supposed to be instantaneous, and it's supposed to be, that's the thing about the brainstem, all right? The brainstem it does it without you having to think about it, right? That's where all of our cardiorespiratory systems are. That's where like all digestion happens. So when people ask, like, you go, okay, this has got to be a brainstem issue. They're like, well, is that bad? And you're like, well, I mean, it can be, right? It can be bad, but in all actuality, it could be that it's just not working as well as it should, or that certain things aren't communicating as well as they should.
And I never like saying bad or good, because the thing is, it's all about your brain's adaptation to the environment that it's in.
Yes.
So when we're thinking bad or good, it ends up like, oh no, I only want good things and I don't want bad things. But that's not really how the brain works or the body works. And also, it has nothing to do with how to make it better.
Right.
So the thing that we want people to understand in our office is your autonomic system is not a seesaw. You do not want high parasympathetic and low sympathetic. You want tightly controlled autonomics like a thermostat.
Well, and it should undulate, right? And you just want it to undulate evenly so it evens itself out.
Exactly. I use the example in the office as a thermostat. You want your thermostat set on 70 degrees. You don't want to wait for it to get 80 before the cool air kicks in. You want it to get 72 or 68. Same thing with sympathetics and parasympathetics. When one goes a little bit high, you want the other one to match it. When the other one goes a little low, you want the other one to match it. So you get that normal undulation of cellular physiological process. And what happens with patients with dysautonomia is they're not responding well. And here's the problem, though. The only thing that can make these systems respond well is better activation and accuracy of the reflexes in the brainstem. You can't use your frontal lobe and do frontal lobe based things like mind-body medicine, unfortunately. Like, it may make things better in the moment, but the problem, the reason why patients get fatigued, the reason why patients get brain fog, the reason why patients get anxiety and depression associated with these things is an overfiring of the frontal lobe, because the frontal lobe is already being asked to do too much to take care of the brainstem. So if you think of all the reflexes that are supposed to automatically do things in the brainstem, they're like the kids. The kids have their own responsibilities. They have to do something, and they don't do it. Then all of a sudden, the parent comes in, which is the frontal lobe, and says, "Wait, you were supposed to have this done. Why don't you have this done? Go sit in the corner. Go. Here's an iPad. I need to go do this now." And the problem is, we can't continuously keep thinking that the frontal lobe needs more responsibility. We can't always go to the jump to the answer of, we need to think our way to better health, because here's the thing. The problem is that the frontal lobe is already error correcting. It's already overcompensating through the basal ganglionic systems. It's already using way too much dopamine or systems and pathways in order to figure out how can I error correct for all these little errors that are happening. If we don't go after those errors and we just go after, let's just find a way to think ourselves to a better place, it's not necessarily going to get us.
Well, and the thing is that might work temporarily, right? But what happens when you undergo a large stress load, right? Or you add one more thing. So a lot of times people will ask, well, I never had this problem before. It's like, well, I mean, it might have been that you were compensating really, really, really well, right? And then something else happened. You either got sick or you got hit in the head or you slipped in. It doesn't matter what it is. Some stressor, right?
Your office, what are the two main things you see causing POTS? Concussions and post-COVID syndrome, viral illness, or a traumatic to the head. So both of them are types of acquired brain injury. And so here's the thing. It's like we're always so focused on why did it happen and how did it happen that those are not meaningful questions.
No, I sometimes am like, I don't really care how it happened. I care about how we can correct it, right? Or how can we address it?
Exactly. And so that's one of the big things is, I actually had one of my intensive patients. So since I've been on the podcast, I've had patients fly in to see me, especially if there isn't somebody near them that can help them. And one patient was, on the second day of the intensive, she verbalized to me that, I thought it was weird that you didn't ask how it all started. And I said, well, you put that in the intake form. So I was able to read it. But you telling me how it started doesn't tell us how to fix it every single time. Sometimes that is important to know to give us an idea of we go in this direction, why not that direction. But most of the time when it comes down to rehabbing this from a functional neurological perspective, the best part is that we don't have to rely on subjective interpretation of what happened. We don't have to rely on subjective interpretation of how our body is working, because let's be frank, our brain is the thing that we're working on that's struggling. Are we really going to sit there and say the thing that you take stock in yourself of, the thing that you use to figure out how you're doing, are we going to say that's the most accurate picture that we can actually respond to?
Especially because that's why you're here in the first place, right? Is because it's not doing its job well.
Exactly. And now, of course, we want to say things not in such a blunt way when working with patients. But the most important thing is the goal is to get patients better. The goal is to figure out what's going on from a biochemical, neurophysiological perspective and gently push them in a certain direction so we can rehabilitate those subconscious automatic reflexes that are supposed to be there and making things happen on their own.
Well, and so I know that a question that's going to come in, especially from like individuals, is like, well, what do you do for treatment? So go ahead, because
So
I know like the beautiful thing about what we do is that no two treatments are exactly the same. Right.
exactly.
And depending on practitioner or patient, like there is no one size fits all for this. So if you're listening, that's the caveat here is there's no one size fits all. You need to have a proper exam. You need to be, assessed. You need to have a neurological examination. You probably want to find someone who's very qualified to do this.
Everybody has to start with the neurological examination. In my office, they're 2 hours, and we do cranial nerve exam, balance testing, peripheral nerve exam, coordination testing, video oculography. We measure a bunch of eye movements to get an idea of where the errors, and based off of a hierarchy and order of operations, then we respond to those things and we design a treatment plan. The treatment plan is very, very fluid because, like I said before, you use your eyes, your inner ear, and your muscles and joints to map out the world. So the work that we do is a combination of vision rehab, vestibular rehab, proprioceptive or physical rehab, and cognitive rehab integrated, where we not only look at them as individual silos, but we look at the reflexes between them as well. And that's the most important part that makes us different
than like a pharmaceutical intervention, right?
Or nutritional intervention. Mm-hmm. And the whole point is we want to make sure, and we also do in our office work with a nutritional approach, but we want to get the fastest results possible. So what usually we do, we start with a neurorehabilitative approach, and then we find a nutritional approach to maintain it, because we find that to be the quickest, fastest way to get some patients better. That being said, and you're well aware of this as much as I am, that even within the functional neurology world, there are different approaches to treatment as well.
Definitely. Because my approach even is a little bit, I do the same thing. I call it layering my therapies, right? So we're going to add this layer, and then we're going to, coordinate them all together and see how it works. And it might work really, really well. It might work kind of well. There might be something we can do a little bit differently. I also do a lot of blood work in my office, but it also depends on the condition, not on everyone, right? That's the importance of like treating the individual, not treating the condition, right?
Totally. And I find that it's so important to do that. But when I talk about timescales and money best spent and the cost benefit for the dollar, I'll do blood work if our primary approach doesn't work. And typically, to me, that means I send them off to a functional medicine specialist,
right,
who can handle prescriptive medications as well. I had one patient who I'm pretty sure that the medications that she was put on for other problems gave her the POTS.
Right. I've had that as well.
But what the other thing is the whole concept of a rehabilitative model, being able to be rehab heavy, focus first, and changing things and picking therapies based off of how they present in real time, I've noticed is also very selective where you learn how to do functional neurology, which is why you and I practice very similarly.
Yep, absolutely. Well, and the nice thing too about especially something like POTS, right, is that usually there's a defining onset. Not always, but some like, oh, I got this and now I have this, or I got hit in my head and now I have this, versus something like where if it's like generally unresponsive brain fog or something, then you might want to dive into the blood work and stuff like that a little more deeply to make sure they're not anemic or something like that. But for stuff like this, I think that the biggest takeaway from all this, if you're listening, is that so there is a lot of options, right? There's a lot of options. You just have to find the practitioner, especially if this happened, like say after a viral infection or traumatic brain injury or something like that. And it has been unresponsive to treatment thus far. There are other options. You just need to find a qualified individual to do it. And that, that individual needs to do something like a comprehensive neurological exam so that they can come up with the appropriate management plan.
The other thing that we offer at our office is if you go onto our website and click the Get Started form, what it'll do, it'll send in a form, we will respond to you, and we will get you set up to have a conversation with one of the doctors. We offer a free 30-minute consult with everybody because you know what, that's important. You want to make sure, A, that it's a good fit doctor-wise, and B, that you're in the right place. You don't want to walk into a place, do an exam, and find out at the end of the exam you're not. It was a waste of money, waste of time, or wasn't the best fit.
Right. So if you guys are listening to this and you'd like to find that information, I will actually link the website for Dr. Lovich and Delta S Performance in the description. And yeah, you can get started there. Dr. Lovich also has a really cool tool that he's been working on, which is a doctor locator. Is that live yet? I know that you've been working on that.
Oh,
for quite a while.
It's been live for about a year now. Basically, it's a people that I personally have shadowed. Most of them are people who have, for lack of a better term, trained in the dojo of Z. But it's most people that if I had a brain injury, if I had an issue and I was in their town, those are the people that I would knock on the door and go be a patient as, for personality, for quality of care, for ethics, and for clinical relevance and clinical skill to actually getting a person better. Those are the people that I would be reaching out to personally.
Well, excellent. And as always, so we'll probably wrap this up. If people want to get a hold of you, Mike, what's the best way to do it?
Go on the website, click the Get Started form. If you're a patient or in the general public and you're looking to ask questions about yourself or a loved one, click the Get Started form, get on a phone call with either myself, Dr. Fossey, Dr. Andrews, and we'll be happy to answer any questions that you have about your case or your loved one's case. If you're a practitioner listening to this and you want to have questions, you want to go over a case with me, or if you want to just chat with me in general about yourself, or you want to connect with me from professional to professional, go to the Contact Us page, and there'll be a page there's a little form there to fill out called Professional Collaboration. Fill that one out. Those are probably covering most people who are reaching out to the office.
Excellent. And if you guys have any questions as far as, regarding the podcast or anything, you can always get a hold of me at info@brainstormingwiththedocs.com. I check that semi-regularly, which is saying something because Mike knows that I never check my email.
That's the worst. I'm surprised you're on a computer.
Yeah. But all right, man. Well, I really appreciate it. We should do another one of these because you're just chock full of information. I definitely enjoy picking your brain and listening to you talk. So yeah, appreciate you, and we'll do it again soon.
All right, Dr. Glenn, what'd you think?
I thought that was amazing. I'm not playing in the world of neurology like you or Dr. Mike, but I'm constantly fascinated, not only, the mechanisms of it. We always talk about mechanisms, but I'm kind of out of the loop in all the neurology, and I pick your brain a little bit, but this was super interesting and how he broke it down. POTS, and I see it. We were just talking just now of what I do when I see it versus what someone versed in neurology would do. It completely different. The component of POTS and how, I don't know how, and I don't see as much of it as you or him, but how destructive it is in people's lives when it gets bad enough. And when I get severe case like that, well, I got to send them somewhere else. But when it gets that bad, and then they bounce around the medical system without a strategy, that's maybe the most burdensome. What do you see when you see POTS? And do you see?
Well, here's the thing. I have a patient right now that has, he had it. We'd had it pretty well managed, and then he got sick, right? And all of his symptoms came back. And right now, I was actually gone for a little while. On a trip helping my brother. And when I came back, it's like, it's not gotten any better. Like, it's gotten significantly worse, where the anxiety is super bad. The fatigue is really bad, where I can't do something as simple as like folding a load of laundry or whatever, like anything that requires a like excessive amount of postural shift, right? They have to change their posture. Then the symptoms are going to come, right? And that leads to a whole host of other issues too, like anxiety, right? Yeah. And then all of a sudden they're down the rabbit hole and they're like, well, we'll put you on, this pharmaceutical, or we'll try this pharmaceutical. And then all of a sudden you're going, okay, are we getting ahead of this? Or is this a side effect of one of the medication? Or is it, something that's being caused by something else? So then it gets really complicated, right? And there's some of these people I saw a patient actually similar to Dr. Mike when he was in his interview that actually was caused by a medication, like a toxicity. Mm-hmm. And it was really difficult. It took me like 6 months to get ahead of it. And I know a lot more now than I did at that time, even because you're always constantly learning, right? And there's new literature coming out, and you're constantly learning, and you're learning how things project to each other and how they talk to each other. And you get better as you've been in practice longer. Because you don't, believe it or not, know everything as soon as you exit school.
Yeah, unfortunately.
As much as I wish that were true, that is just not the case. So you develop, your clinical acumen, like your observational skills get a little bit better and your treatment options get a little better, and you get a little bit more creative in how you're layering therapies and stuff like that. But a lot of these people bounce around for a long time and never get answers. And it really can be debilitating for not only them, but their family members,
For sure. And then there was a couple other things that I picked up that I had no clue of. Frontal lobe versus,
kind of a big deal.
versus the brainstem. And if the brainstem's not doing what it needs to do because of XYZ, dysautonomic, whatever, the frontal lobe jumps in to try to work. And he put it in a very eloquent way of parents and kids. And I loved it. I thought, I never realized that. And I see a lot of dysautonomia and causing all sorts of bizarre symptoms and not everything is POTS with dysautonomia,
right?
But how
makes you kind of think about it, doesn't it? Like,
it does.
It
makes me think of
options.
Maybe think about case, because if we don't see it in the clinic, well, then that's one thing. If we're testing, however we're testing, but if we do see it, and then we end up with a sacrifice of blood flow and the oxygenation, and then all the other downstream neurological effects of the brain not having what it needs.
Right.
Oh my goodness, the fatigue, the emotional health challenges, the blurred vision, you name it.
No gastrointestinal issues. I mean, we harp on a lot of this stuff each and every week, but it really kind of makes you think about like other aspects that even as you as a provider didn't think about, right?
Mm-hmm.
Like, what could I do in addition to, or who do I need to send this patient to in addition to working with, so that we can get this stuff addressed? Because I mean, something's better than nothing, but having complete and comprehensive care and like fluid care, even amongst providers, is sometimes imperative for these patients.
Yeah, and it's hard to do. It's hard to do from different sides of the aisle. Everybody's got to be open to it. And the more people you bring in on a project, the more challenging it is for the patient, because now you got all these touch points, and in conventional medicine, it's very difficult for all the providers to communicate. It's just not a system for that. It's just not a system for it. So I thought that was really interesting. Then I thought, I didn't even realize you did it in practice, where when you break down a neurological disorder, a neurological problem, we'll call it a problem, into layers of treatment. I thought that was interesting. I do that in functional medicine. I'm steady, looking at different organ systems and try to separate them as much. Of course, there's overflow. You called it layers. And in me, I'm looking at organ systems, and you don't just do this and then check that box and you're done and you work with this organ system.
Yeah,
but
it's
at least
really
you have
fluid.
a starting.
It makes it difficult, right?
Yeah, but at least you have a starting point, and then you have objectives of systems. Because if you're trying to tackle everything, like I see on a blood panel, just at the end of today, there's like 7 big things wrong in this blood panel. And the patient I was sitting with, they're like, well, we need to do this, and we need to do this, and we need to do this. And I said, yes, we do. But we can't do it all at once. We have to focus as closely as we can on one system, and we don't have to fix everything. You just have to fix the right things, and the other things usually lift.
Yeah. I always like to use the analogy that you have to like stand before you can walk, and you have to walk before you can run. Right.
Yeah.
So, and you have to have endurance. And that's a big thing in the neurology world, is like, even if you fix it and there's no endurance, right? Or say you're rehabbing the right thing, but it's so fatigable, right? And then you push it really, really hard, that can be counterproductive, right?
Crash.
So you've got to make sure that the whatever you're trying to do, it is able to tolerate it appropriately. Mm-hmm. So that's the kind of the fun part. And that's the part where it's always like a tinkering type of thing. And I think that's where your like observational skills come in, whether that's on blood panels, or whether it's on like good history taking, or even if it's on like things that you're looking for neurologically, where you're like, ooh, that might be a fatigue point. Could we do something else that might get into like a back door that would work a little bit more effectively? Or do I need to do this, but do it more frequently, but for less duration, so that they have more time between intervals for rest? I mean, that's where the tailoring of the program really comes into it.
That's right. Yeah. And again, not everybody has the same fit or the same strategy. It's all based off where the person's at, right? Where the patient's at.
Yeah.
Otherwise, the therapy could turn into extremely damaging.
Yeah.
If there was a cookie cutter system.
Mm-hmm. Mm-hmm. Yeah, no two people are exactly the same, and no two providers are the same. There's been a lot of times where I've picked Dr. Mike's brain about certain things, and he goes, well, did you think about this? And I'm like, no, I didn't. Or, Dr. John has been on our podcast before. He'll call me and be
Yeah.
like, hey, what's your thoughts on this? Well, did you consider doing this? No, I didn't. Well, I mean, maybe that's an option. Well, how,
Yeah.
and then you call them back and you're like, how'd it work? Like, oh, it was, it worked good, or nah, it didn't do
It
what we thought it was
sucked.
going to.
Give me another
And
idea.
that's where, again, the observational skills come into it.
Mhm.
So,
Yeah. Well, that was good. I'm glad he came on. Hopefully we can have him again for another,
yeah,
another
he's
conversation.
he's full of information. He's really articulate. I'm really good friends with him. I talk to him really pretty regularly. So I'm sure that if we have something that we find interesting, that he's more well-versed in it than we are.
Yeah,
then
maybe we could even bring
up
up a case study if we can get a patient that's willing to be part of it. That would be
for sure.
good. Yeah.
And again, I will link his information in the description. Again, his business is called Delta S Performance. I think it's DSP. I'm going to butcher it, so I'll just link it. But I think if you Google Delta S Performance, it'll show up. There's a bunch of locations. If you guys have any questions associated with podcasts or potential topics or whatever, you have a question for Dr. Glenn or myself. Again, our contact information for the podcast is info@brainstormingwiththedocs.com. You can obviously get on our web pages. Mine is northlakeschiropractic.com. Dr. Glenn's is drgharrison.com. Or leave a comment in the comments below, and we'll get those read and get back to you as well. And stay tuned, because we're going to continue to roll out new content, new providers, new information each and every week. And we hope something that we do is applicable to you. So till next time.
That sounds great. I appreciate it, Dr. Kolby. I look forward to the next one.
All right, buddy. Bye.
Bye-bye.